Michelle, are you settled?
More or less. Or we haven't really settled.
Hey everyone, if you're watching our YouTube recording, you're behind the scenes with our esteemed roundtable of guests. We are about to go live in front of our studio audience via Zoom, so just bear with us here. We get a little bit behind the scenes with me and the group here. All right, folks. We'll also take questions. Cindy, I don't know if you have the bandwidth. You can keep an eye on the Q&A module. If there's a question specific to you, by all means, you can type in the answer and then share it with all. I will try to sprinkle in questions from the audience as best as I can. And if there are questions you can't answer, just keep it informal and just call it out that you can't answer it. Same with you. All right, great. Here we go. Greetings, everyone. Hello, this is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared on this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. Our topic today, how conquering loneliness is a key to your Medicare and Medicaid businesses. And we have the perfect set of experts to share with you their insights and bright spots around this topic. I'm going to introduce them to you very briefly right now. Our first guest is Michelle Bentzine-Purrington, Senior Vice President, MLTSS, and the SDOH Innovation Center at Molina Healthcare. Michelle has been with Molina since 2005 and oversees their managed long-term services and supports strategy for more than 375,000 individuals in 14 states. She also leads Molina's National Social Determinants of Health Innovation Center. So Michelle, welcome to the show.
Thank you.
We also have Cindy Jordan, co-founder and CEO of Pix Health. Cindy co-founded Pix in 2018. She leads the company on its mission to effectively address the healthcare crisis of loneliness and social isolation by finding and perfecting a balance of technology and compassionate human intervention. And one of my favorite things about Cindy, as far as her bio goes, in a past life, she actually spent 5 years as a cop, a police officer in the Washington, D.C. area. You could ask her questions about that later on. I also want to thank Pix Health as being our supporter and sponsor for the show. As I tell all of you each episode, without our sponsors and partners who bring not only expertise to the show, but funding, we could provide you this programming each and every week. So thank you to Pix. They provide a platform that combines a friendly technology application with a call center staffed with certified compassionate humans, and they work with health insurers to demonstrate and provide improved loneliness, impact loneliness in a positive way that improves total cost of care. I'll tell you a little bit more about them and Cindy later on in the show, but you could check them out right now at pixhealth.com. I'm going to spell that for you, PYX Health, that's one word, .com. We were scheduled to have Helena Belli, she's the Senior Director of Social Determinants of Health Innovation at Centene, on the show as well. This rarely, I don't know if that ever happens, but Cindy kind of got struck with a bad flu-like virus and had to cancel just a few hours ago. So we hope that she has a speedy recovery and is able hopefully to enjoy the long weekend at some point, and we will carry on without her. Final PSA before we get started. Two things. If you want to co-moderate this interview with me, there's a Q&A module that you're probably all very familiar with in your Zoom application at the bottom of the screen. Sherry Kale is our producer, and me will be monitoring that. Please submit your questions throughout the conversation through the Q&A module, and we'll integrate them throughout the conversation. We should be able to have a lot of fun with that, some flexibility in taking questions from all of you as our conversation evolves over the next 55 minutes or so. And also, you're going to receive from me yet another email in about 45 minutes. No apologies for me on this one. We use this communication, this feedback request that's going to be coming to you via email. It's a SurveyMonkey, no frills, to make sure we have some two-way dialogue with all of you, our live listeners, to make sure we cover the proper programming moving into the rest of the year. Our regulars who listen to the show every week know that we rely on this to enable us to provide you an hour of valuable content from your busy day each and every week. And we'll also ask you feedback on how we can improve ourselves operationally as well. So thank you in advance for taking the time, about 3 minutes, maybe 2.5 if you're quick, to click those buttons on the SurveyMonkey and provide us with some direction for the rest of the year. All right, I want to level set with a question to start our interview here around loneliness and how all of you should be thinking about loneliness. I'm going to bring in Cindy Jordan, CEO and founder of Pix Health. Cindy, how should everyone be thinking about loneliness? We know it's a social determinant, but is it more than that? Just so everyone kind of thinks about loneliness and social isolation in one way as we continue on our conversation with you and Michelle and me.
Yeah, I mean, it is obviously categorized in the healthcare system as a social determinant, but it actually acts more like a chronic condition. And in my humble opinion, I do believe that loneliness is a chronic condition. You know, there are more adults struggling with loneliness in this country than diabetes. And there was a New York Times article about a month ago that talked very directly about this. And if you think about the resources that are going towards diabetes versus loneliness, you know, it's stark. You know, the reason I think loneliness is a chronic condition, and I think very soon we're going to start to see it treated as such, is because it truly has a scientific physical response in the body. The physical effects are like that of significant anxiety or stress. You know, the body starts to release cortisol, which of course, as we all know, affects us both physically and mentally. You start to develop these negative thought patterns. It's actually a rewiring of the brain. You know, you tend to isolate, and so isolation is the physical, condition of being alone. Loneliness is all of these feelings that we're talking about. It starts to have a negative impact on blood pressure and sleep patterns and obesity. And it's similar to like an individual, I think I read this in an article recently, where they feel like they're in dire straits. So chronic loneliness has an acuity. And all of that leads to thinking of loneliness as a chronic condition that frankly is deadly.
Thanks for that, Cindy. And with that kind of laid out, let's talk about solutions, how we approach solutions. And so, Cindy, how is Molina building a sustainable and potentially scalable program to not only identify members, but support members who are suffering from loneliness?
Great question. So the key to addressing loneliness is making meaningful connections. And what's meaningful, that's determined by the person, by the individual. So there's not a one-size-fits-all solution for addressing loneliness or creating social connection. The first key is identification. And as a priority at Molina, we listen to our members. We ask them questions, sometimes very explicitly and sometimes in a more roundabout way, about social connections and engagement with other people. We also have really sophisticated predictive analytics that we use. Data is out there and it's powerful when it's harnessed appropriately. So we use information from our members, providers, public resources to help us identify people who are at risk. The second key strategy is to give people options that are easy to access. And we've partnered for years with community and faith-based organizations, schools, agencies that offer classes, group activities, peer supports. We invest millions of dollars annually in these community services through our Molina Cares Accord, which is our commitment to building stronger communities through improving people's health and lives. We partner with providers example, as a Medicaid provider, we cover long-term services and supports for part of those that we serve. So we contract with nursing facilities where people live. And that can be very isolating, particularly during the pandemic. We saw an escalation of loneliness of people living in facilities and institutions. So one of the things that we do is fund on-site activities and field trips that encourage social engagement and community connection, which are all strategies to combat loneliness. And we do this, we offer these benefits to nursing facilities who achieve high quality scores. Scores on quality indicators they're already reporting through CMS. And when they do really well, and those things are tied to health outcomes, we can fund these programs that offer social connection. And then the other thing is, actually, I'm going to have to talk about PICS here happily, because loneliness doesn't have an 8 to 5 clock. So even though we have 24/7 crisis lines, nurse support lines, providers offer services after typical business hours, people aren't always in crisis. They're feeling lonely. And what PICS did for us is offered an alternative 24/7 to give people a way to connect. And what we've learned through that program is in the middle of the night, between like 10 at night and 4 in the morning is when people engage most frequently. And our experience through this process is really important. We've seen a 50% reduction in loneliness, 83% reduction in members that are screened for depression. And I have all kinds of stats on the reduction of avoidable healthcare costs. So very, very promising practice using both solutions we already have in place with providers and community partners and public agencies, and adding PICS as an additional mechanism and solution for connecting.
A couple of follow-ups. That's great. First, let me try. Sorry, I'm looking at the Q&A module, trying to do two things at once here. So let me try to summarize that, because I was taking some notes. So just summarize it for the audience. You could tell me where I missed some things. So first is use public resource. You guys are using public data resources to identify risk of social isolation. You're investing in resources to partner with local organizations like faith-based organizations and community health centers to provide programs and access points for people to engage in. You're also, and I separated this as a number 3, is you're actually working directly and contracting with nursing facilities where people live. You'd like to think that there's a lot of people there, so there's not actual loneliness, but there actually is, and you're funding on-site activities and field trips to promote social interaction. And then the fourth thing, because a lot of the folks, the loneliness manifests itself often from 10 p.m. to 4 a.m., I think is the hours you gave us. You need to provide them with a way to connect in those hours, and that's where you really rely on the program at PICS Health to do that. And you've seen results in basically dropping loneliness by 50% and depression by 80%. So those are the 4 things I wrote down as you were that I typed while you were talking. Sorry. Did I miss anything? Is there anything else?
No, you're a great student, Eric, and a great summary, but again, not one size fits all. So it's really important to have multiple strategies. And we have a great community infrastructure throughout the United States. A lot of not-for-profit organizations that offer programs that combat loneliness. And PICS is just as an adjunct to that, which is a very important part of our social ecosystem.
So I have one more follow-up, and then I want to go into sort of the physician role in primary care. But we did on the show a couple years ago we did a show on peer support and peer-to-peer support. You mentioned peer groups in your answer as well. And I'm curious, because I'm fascinated by this and think probably we should do another episode on this. In fact, Sherry, if you don't mind adding peer groups to the feedback form, it's one of the options our listeners could choose for another show in the future in 2022. What are your thoughts on how effective are peer groups? And if you may not have any examples. This goes outside of our prep call, so you know what I mean? But like, what have you seen as around the power of peer-to-peer as it relates to healthcare in general, and if you want to get specific to loneliness?
Yeah, I'll start, and then Cindy, please jump in. What we find is peer supports are used in a lot of different forms. Traditionally, it's been used with substance use and supporting sobriety, but the application goes beyond that. And basically, people with lived experience have a different approach sometimes to engaging individuals, and they're more credible. Now, the bottom line is, okay, as a female who's given birth to children, my experience in engaging and helping somebody who's going through postpartum is going to be different probably than yours, Eric, right? Never having given birth. So peer supports can be a very, very effective solution for people. And again, bring that credibility and relatability to the individual that's experiencing loneliness specifically. Cindy, I don't know if you have more to add.
No, I think you said it perfectly. I mean, from the business side of things, I think that healthcare is and should, be embracing more and more of the peer model. And I know that sounds like a shameless plug because that's essentially what PICS replicates, but it's affordable, it's scalable, and it has really significant impact. And so, if you're just following the money, the peer support model is highly, highly effective.
Yeah. This is and this is why I did the show in 2019 or whatever that episode was. And I want to do more of this. Is one of the bright spots I looked at very early on when I started the show in healthcare, as we think about sort of the chronic care epidemic in this country, is Alcoholics Anonymous. And even though not everyone loves that program, it has stood the test of time through generations. And the core component that makes that program tick is your sponsor, which is, for those of you who don't know the terminology, basically your peer mentor, someone who's also an alcoholic who's been in the program for a while, and they're your peer mentor. So when you look at those components and what makes that program sustainable, it's tied to peer. And so I'm looking and exploring applying that in different areas of healthcare, because you see it happening informally in social media, more formally at other organizations where peers are helping peers and not even doing it volunteering out of the goodness of their heart. And so, I think it's a really powerful way to unleash the army of the ill, the sufferers here, to help other sufferers, which is also therapeutic in of itself. But I'm going to get off my soapbox. I have a couple follow-up questions from my co-moderators here. I think this one will be for Michelle, and then Cindy, if you want to jump in, if Michelle doesn't cover it all. Given the fact that self-reported surveys have not been found to be a good evaluator of social engagement solutions, what other metrics do you use to identify who is lonely, what programs work, and which ones don't?
Great question. So we use a multitude of key indicators. So we use both self-reported information, but also we engage with individuals, clinically trained individuals are engaging with people, and they are assessing folks' level of loneliness and social isolation. We also look at HEDIS measures, depression scores. Use and engagement of the healthcare system is actually an indicator of loneliness. People who are lonely that engage with the healthcare system actually have reductions in loneliness. There's research around this. And also we look at overall social connection and activity rates. So just the amount of time people do things with other people rather than being isolated is an indicator of success in loneliness. What do you have to add, Cindy?
I think that's right on.
I have another question on Molina and loneliness. How is Molina measuring the impact and then monitoring the quality improvement over time?
Great question. So a few things. We're looking at total overall cost of healthcare and access, so avoidable emergency department utilization, inpatient readmission rates, use of emergency psychiatric services. We also look at depression indicators, follow-up visits after certain types of hospitalizations and other visits. There's the key here is there's a myriad of already good validated measures that we're leveraging. And you know what? Those are all really important, but we cannot lessen listening to the person. When a person reports their level of engagement, how they're feeling today over time, and you measure that, great versus okay, that's a really important indicator. So I think all the validated, nationally recognized indicators, health indicators are important, but also we have to listen to the voice of the person.
I want to, Cindy, I'm going to come to you next. I'm actually going to talk primary care in a moment. Michelle, I'm calling it audible. So Cindy, as we're talking about all of this, and Michelle has mentioned some things about identifying chronic sufferers of loneliness, but you guys take a very technical, analytical approach. Could you just sort of outline, how you are identifying these elusive members who are suffering from social isolation?
Yeah, I mean, it took us a while, candidly, but we've been in the market since 2018 and have served tens of thousands of, members. And so we've been able to sort of develop a persona around a chronically lonely individual and how to find them. I saw someone in the chat said, lonely people don't go to the doctor. That is absolutely true. They don't engage in preventive care. They don't go to the doctor, but they do utilize emergency services, and not because they, for physical health conditions. So we had what we've created, what's called the loneliness index. And it's an algorithm where we use claims data, some publicly reported data, like Michelle said, but primarily what we're looking at is an individual's recent 12-month utilization, specifically around ED and inpatient admissions. We also take into account whether or not they have BHPH comorbidities, so behavioral health, physical health comorbidities. We look at things like, do these folks, have they had an MSK admission, for example? Like, are they going to the ED with like unidentified back pain, for example? So there's a lot of, have they dropped off of their medication adherence? There's a lot of points that go into us, and we run the algorithm on the list with our plan partners. But then we do something that I think is critically important, is we also try to find people who have a propensity to want an intervention, because it's important not just to find the chronically lonely, but those who would be willing, to have a potential intervention like PICS or any of the a number of things that Michelle talked about that are in the community. So once we find these folks, we use evidence-based screenings to identify really where they are. And that's important because it's, you can't rely on somebody just to say, I'm lonely. Firstly, most people don't. There's a stigma attached to actually admitting that you're lonely. You may live in a house with 10 people and still feel very, very alone. So once we find these folks, we use evidence-based screenings and social determinants of health screenings, and we start to develop a complete picture around the people that we're serving. And when we find chronically lonely individuals, we put them in our Thrive program. And that is an 8-week therapeutic intervention that uses not just the technology, but our human beings to do regular interventions. And we've had wild success with that, not just in decreasing loneliness and staving off unnecessary utilization, but in decreasing depression, as Michelle said. So a number of Michelle's members are actually active in our Thrive program.
Awesome. Awesome. All right. So let's now talk about the fact that if you're suffering from loneliness, you're often not engaging with a doctor, Michelle. So how are you leveraging primary care then to reduce, loneliness?
Well, a couple of things. First of all, people who are lonely do go to the doctor, not as much as people who are experiencing extreme loneliness, but they do. And our provider partners are expert in teasing that out and identifying it. And so we align incentives. We make it easy for physicians and nurse practitioners and office staff to refer people to Molina. And we also educate them about the different programs that are available to help combat loneliness, so that they could do a self-referral right in the office and provide information at that point of service with the member to address their needs. So really key here is aligning incentives, having our providers help us identify folks that are lonely. And as Cindy mentioned earlier, when people are lonely, they're not necessarily ready to engage yet. So just once we identify someone's lonely, it may be sending a community health worker out or calling them periodically to establish a relationship and trust so that when they are ready to engage, they will, and they have resources. They're aware of the resources available to them to do so.
Very good. I want to, folks, keep those questions coming because they've been great. Actually,
Hey, Eric, can I add one more thing on the
ahead.
primary care physician front?
Yeah.
There's something that I'm not sure who in our audience is aware of. There's a really easy way. Providers submit claims to get paid. And there are now Z codes that can be used. They're diagnosis codes that show or can tell a payer what social determinant of health needs an individual may have. And here's an easy way at no additional cost that providers can make a healthcare company aware of a need, an impending need, so we can then engage and take action or work with them to take action to help people. And one of the things that we did when we saw low use of Z codes, in our value-based purchasing arrangements, we started incentivizing for reporting and using Z codes. So that's a really important, easy best practice. We saw a significant uptick in reported instances of social isolation and loneliness using that technique.
And is that how a PCP then could actually make the referral? Just use
They can. Now, the bad news is claims lag, right? So they aren't as immediate as if you immediately phone Molina or through your electronic health record, send us an alert, but it's still within weeks or months of actually seeing the patient. So it's still a valid data source and input. And over time, particularly if someone's seeing a physician on a fairly frequent basis, we can daisy chain those data points together and see an emerging pattern or trend.
That's great. Cindy, another question from a co-moderator. Is there a differentiation between acute and severe loneliness when providers screen primary care patients?
Yeah, if they're using the UCLA evidence-based screening, which is widely accepted as kind of the only one, there are levels of loneliness. You know, there are degrees of severity, and there is a high acuity. And I think that score is actually a 6, which is very counterintuitive to me. So it always leaves my brain, but you know, to me it should. But there are degrees, and that's another reason, back to the loneliness index, that people will start to stop taking their meds and maybe have, you know, had an ED admission. So it starts to show itself in claims data. But as Michelle said, that, you know, that's late. And so what you want to do is you want to get in front of people and get this information in real time so that you can stave it off from turning into, you know, having the ripple effect around physical health.
There's a couple Molina questions coming from the Q&A module that I'm going to come back to in just a moment. Before we do that, I just want to give one more shout out to Pix Health for those of you who just or joined us a little bit tardy. Pix Health is the latest new partner to the Bright Spots in Healthcare family, and they have the first proven solution used to treat loneliness. They have a platform that is combines friendly technology with a call center staffed with humans, compassionate humans, and they've showed data where they've been able to reduce loneliness scores and depression by 82% and medical spend by 57% and improved engagement by over 70%. So really impressive stats. And if you want to check them out online, it's Pix with a Y, pyxhealth.com. And then in the feedback form that's going to come to you guys in about 15 minutes, if you want to learn more from Pix and actually meet Cindy, you could request to do that. And I won't just like pass your name on in a list or anything. I'll actually personally make an email introduction. So I'll be involved in that too. And just it's a not to there's no pun intended here, but pick Cindy's brain. You don't need to hire them. Just to get more information around how you should be thinking about loneliness as part of your strategy at your health plan or ACO. So that's number one. So thank you to Pix. But I want to do something I usually don't do in these sort of roundtable formats and get a little bit personal here, Cindy, and ask you just, you know, you've had a career doing all different kinds of things. I mentioned earlier, you're a police woman for 5 years. You also, and you started this company in 2018, so it's not that old, very successful, but not that old of a company. What inspired you to build this company and just inspire you to run PICS in general right now?
Yeah, I mean, for me, it is very personal. This is actually my second healthcare IT startup company. I sold my first one, and had you asked me then if I would ever do it again, I would have emphatically said no. But in 2017, my stepdaughter, who was diagnosed with bipolar, had a bad year. It's the kind of year that Michelle and I have been talking about, right? Like in and out of facilities, ED admissions, inpatient, et cetera. And we, as a family, we were very taken back. And so when we sat down with her, when we kind of got to the other side of it and said, I asked her specifically, I want to understand what comes first. Like, how can we get ahead of this kind of, bad outcomes? And she said, I feel overwhelmingly lonely. And that really blew me back, because she was in college. She lived with a roommate. She came to family dinner every Sunday. So in my definition of loneliness at the time in my brain, how could you be lonely? You have your family around you, you're in school, et cetera. But when I started doing research on loneliness, that's when I came across all the things we've talked about, that this is literally a chronic condition that is a rewiring of the brain, and she can't help it. And then she ended up passing away from her mental health struggle. And so what we do here at PICS, while yes, we are in 52 markets and we're touching thousands of lives every single day, it is about stopping families from having the experience that I've had, with my own kid. And so, yeah, it's a very personal mission here.
Yeah, it's completely heart-wrenching as a parent myself. But thank you for sharing. I just think it's really unique to have such a powerful mission behind an organization. I want to talk again. I want to get back to the physicians, Michelle, because I think people listening need to understand how to best leverage and incentivize them. And so they're critical, right, to being a partner in winning this battle versus loneliness. So I want to ask you a two-part question. One's going to come from one of my co-moderators out there, and one's from me directly. So first, I want you to provide maybe the group with a roadmap on how to activate and engage doctors to support these efforts. Like, what are you doing at Molina? You don't own the doctors, so how are you getting them actively involved in trying to tackle loneliness? And then to that point, the follow-up question from my co-moderator is, can you share more color on what the incentives you offer PCPs for using and reporting Z codes?
Yeah, absolutely. So we start small, and just like we meet members where they're at, we do the same with providers. So we recognize that some providers have very large, sophisticated systems, and some are very, individualized one-stop shops, and all are important. So we start with one, education, making information available so people can learn by themselves on our websites. We also have, in every community we serve, we believe healthcare is local. We have people that within the communities that work with our providers and educate them on different programs available. And we recognize that providers these days are dealing with so many different insurance companies. Like, how can you keep it all straight? So let's just get the information out there, make it easily available to disseminate. That's about education and information. Regarding how you incentivize, a lot of providers are entering pay for quality or risk-based arrangements. And so an element of those arrangements are what percent of members have Z codes that you report or that you make referrals through another source. And we pick things that are most impactful based upon population health strategies and what the data is informing us for those we serve. So it will vary depending on the type of provider and the types of individuals that they serve. But we, again, structure those incentives and the key indicators based upon who the providers are serving, what patients they're serving.
Awesome. I'm going to summarize that because I love these blueprint kind of answers.
Mm-hmm.
Start with the low-lying fruit. Keep the educational info and information about the incentives and the program and the effort simple, as I just rambled a bit there, just the opposite. Also providing, you said it, I don't know how you incorporate this into your communication, but you clearly have empathy for the fact that these PCPs have multiple payers and you're just one of them. So there's an empathy. Maybe expand upon that. Like, what do you do with that information? Do you use a common point person from Molina that's familiar with the practice, or how do you make sure that you're keeping things simple and they're paying attention to you versus the 3 or 4 other payers that they're dealing with and more?
Yeah, we do. We have personalized relationships. And the other thing is office staff, right? The key to getting information in the hands of the practitioners is make it easy for the front office staff. So we do have dedicated individuals by region and even by provider type. So I mentioned that my primary responsibilities manage long-term services and supports. That's a whole different type of provider than a hospital system. So we have people experienced and expert at each of the provider types who are their primary source of engagement. And then with our larger provider partners, we actually do joint operating committees, and we cover how they're doing on some of these key important stats and metrics. And for those that are not large scale providers, we still provide data and reports. It's easy to access through their provider portal, through other common provider portals that are used in the industry that we link into. Try to make it as easy as possible for one-stop shopping for those providers.
Great. So number 3, I'm doing the roadmap, right? So low-lying fruit, simple information, and then aligning incentives, right, was the third thing. And you talked about pooling incentives together. You mentioned risk, and one of those criteria is maybe what percentage of Z codes.
Yeah, and let me get even more specific. So earlier in the podcast, I mentioned that through PICS, we have seen reductions in total cost of care. Well, the primary, most expensive healthcare drivers besides, pharmacy are inpatient utilization and emergency department use. Those are 2 measures that we've seen statistically significant improvement on. And so as we have overall reduction in healthcare utilization, we can use some of those dollars to pay back to our providers who are helping us get those outcomes for individuals. And so as they increase reporting, that's one step. As we start to see outcomes, we'll share in that savings. And so we integrate those shared savings into our different value-based programs.
And what about the providers who aren't doing well with this? Like,
Great question. You know what? Providers are pretty phenomenal. And a lot of times, if they're not doing well, they don't know. So empowering them with information. And if that's not enough, asking them what's it going to take? What is your barrier? Why do you think this isn't working the way we all want it to? And then we bring best practices to them. So if we have a provider, across town who's doing a great job of knocking it out of the park, we have visibility into what they're doing well. If we can offer some strategies without giving away any, trade secrets, again, sharing those bright spots, we're going to do that.
Do you offer specific training to providers around recognizing loneliness and recognizing when when providers may, in their rush to do their jobs and in the harried lives that they're sometimes forced to live, that maybe they're not putting empathy first? Is there anything that you guys provide?
We do that's combined within our cultural sensitivity training that we provide to all providers. Does it get specific into diagnosing depression or loneliness? Obviously not, because that's what they're trained medically to do. But it is part of cultural sensitivity and the culturally appropriate engagement model.
Nice. Cindy, what about your folks who are on the call center, those folks that have sort of that the empathy and the human touch? What kind of training do you put your PICS employees through to help them support at-risk patients?
Yeah, I mean, our compassionate care center, we call those folks our Andes. And that stands for authentic, nurturing, dependable, your friend. And every Andy is certified in something. Generally, it's peer support or behavioral health technician. And then they're overseen by a clinician. So it's run like like you would imagine, with a very rigorous training program, de-escalation, crisis identification, on and on and on. And more importantly than just the training, there is a quality program that lays on top of it, right? So, you know, we adhere to like the highest standards of providing care. You know, while we're not technically a provider, we don't actually bill, but we run the call center in that way. These folks are not just plucked off the street and given a handbook and allowed to become an Andy. Like, you know, they have shared experience, they're trained, they're QA'd, and they're overseen and rigorously.
I want to switch gears for a moment. And Lois, I see your question there. I'm going to actually bring that into the conversation in a few minutes. So stay tuned. But Cindy, I want to talk about DSNPs. They're the most complex members typically. Could you talk about, or maybe provide an example of how you go after reducing loneliness within a dual population, and maybe share some of the results?
Yeah, actually, we started in duals, believe it or not. I think that is very counterintuitive for an entrepreneur like me to go after one of the hardest markets, but it was important to me given Riley's experience. And so we use the loneliness index really to just like we do with any Medicaid, Medicare population to identify the duals that are at risk. The results that we've seen, and we've served, really thousands of them, is that 65% of dual members that we get on the platform, we decrease loneliness for. And, they also have a high rate of having some kind of a urgent SDOH need as well. So 40% of the duals that we serve will have an urgent SDOH need. And our Andys also are trained in intervening along, with our health plan partners. So when we're talking with someone, providing compassion, putting them through the Thrive program, and we learn of an urgent SDOH need, we'll try to address it in the moment. In fact, we pride ourselves on doing that. What we've seen is that the highest connection between loneliness and SDOH needs in the duals population is health literacy. So if you just think of that in practical terms, it is not unusual for us to help people book appointments with their physician, help them we will literally call the pharmacy with them and make sure that they can get their meds, et cetera, help them fill out forms. These are things that are critical in getting somebody back to the path of self-management. And then Michelle's touched on this, but what we've seen in the dual population, and we have a case study on our website, Eric, that was just duals, is a significant reduction in utilization, particularly around ED and inpatient. And
I'm sorry to cut you off, Cindy. Is that the Banner Health one with the two medical leaders?
Yeah, so we've had several partners conduct independent case studies. This is important for the people on the call. We did not participate in these case studies, but Banner's was centered exclusively around duals. And they've rerun that data now for 2.5 years. So that data is very solid, statistically significant. And basically the punchline is there's a 57% reduction in medical spend when you treat loneliness.
Are you okay? Could we share that with folks?
Of course. Yeah.
So why don't we do this, everyone? I actually read this case study in preparation for today's episode. Sherry, do you mind let's put up a poll, and then people who are listening live can request a copy, and I'll send you the PDF so you don't have to go searching around for it. And if those of you who are listening on the podcast, why don't you either email me at eglazer@sharedpurposeconnect.com, and we'll put up a form as well if you just want to go to the website. And why don't we do sharedpurposeconnect.com/lonely? We can just put a quick little true or field form if you want to request that case study, and we'll get it out to you. So continue on. I'm sorry, Cindy.
No, I mean that's pretty much it. I think the white paper is a really good third-party kind of independent way of explaining how we can impact the DSNP dual population. I have seen in the chat and a few of the comments about, Eric, if you don't mind here for a second, does this work for seniors? And the answer is unequivocally yes. It doesn't mean that they are, that you will see a difference in tech utilization and human utilization the older you get. But generally speaking, the 65 to 85 population is very, very engaged in the technology. And that goes back to the stigma that I mentioned earlier in the show. The 85 plus population, they'll definitely leverage the Andes a lot more than they'll leverage the tech, which I know makes sense to everybody on the phone. But particularly in the dual population, of course, we're serving people. I mean, on our platform, we serve people 14 to 104.
Wow. Great. I want to, Michelle, bring you back in. Lois had asked a question a while ago, and I was just waiting for the right moment. I guess now is as good as any. How are you at Molina finding and comparing solutions that are online, whether they're telehealth, intergenerational, in person, and have the various different methods? Are there comparisons? Are there various studies? Is there different approaches you take to comparing these solutions to show what's working better than others?
Yeah, great question, Lois. Sorry, it was too long of a response to easily type in chat and stay engaged. So the first answer is a lot of times vendors approach us. People have a solution to sell, and they come through direct connections to everyone in the company, and oftentimes multiple people within the company. Secondly, trade shows. A lot of individuals come to us through trade shows, and that includes community-based organizations and not-for-profits, which is wonderful. And then we have people out there in communities and nationally and even internationally reading research and looking at promising and best practices, listening to shows like Bright Spots, because that is really where what's interesting to us is proven solutions and emerging solutions that have evidence-based, which is why PICS was so exciting to us. The second part to your question is, well, then what do we do with it? Well, we vet them internally, and we don't have an open checkbook. Molina is specifically serves folks who receive assistance through government programs. So it's all about, you have limited funds. How do we most responsibly use those funds to help as many people as possible? So we go through a very, very strategic approach on what are the needs of the people we serve, and does this solution match those needs? And then we go through a pilot period. Finally, about comparisons, we do a lot of things in pilots. Do they work on a small scale? And then what does it take to scale them? So when I look at comparisons specifically around loneliness, we have not yet done comparisons of PICS compared to enrollment in a community-based program that's face-to-face. Part of it's because we've had a relatively low uptick in enrollment in face-to-face programs, particularly since the start of the pandemic. So that's been a little tough to do for loneliness.
I'm going to ask you another question that I planned for Halida. So see, I'm putting you on the spot here. So, and if you could pass on it, there must be potential potholes that health plans need to avoid. And if there was a failure or a misstep or something you just may have managed or done differently, if you could go back in time and do it again, could you share that with all of us?
Yeah, absolutely. Happy to do that. One of the things I'm going to build off of is what Cindy was talking about with people 65 and over. One of the potential potholes, and this made me so happy to run across it, is people 65 and older were reluctant to engage because they thought they were getting scammed. And it made me so happy because they've become so educated about potential scams that they're actually questioning. So one of the things that we have to be very thoughtful about is how do we get the right information to people so they know this isn't some scam, that phishing expeditions are going to steal their identity. So that's really important. The second thing is, regardless of age, not everyone is technologically proficient. So I love the idea of partnering with trusted community-based organizations that offer technology assistance for particularly those 85 plus, because my 99-year-old great uncle actually became a technology user with some help from his church. People with intellectual disabilities can certainly benefit from these types of programs if they get some technology training and assistance. So those are a couple potential potholes. And then lastly, I would say, well, again, one size doesn't fit all. So PICS is a fantastic solution. One thing I love about Cindy and her team is they don't profess it's for everyone, but it's a fantastic way to reach a lot of people. It's very scalable. And that way resources can be allotted for people who might need a higher touch model, which is fantastic because we can reach more people who are lonely and give them solutions that work for them.
Hey, Michelle, are people comfortable in general accepting and sharing that they're lonely?
The answer is no.
That's right.
Especially with social media, like everybody wants to live this Instagram life, and that is not how the world works. And there is a stigma with admitting you're lonely, just like being depressed. And Cindy probably has more to say on this topic.
Yeah, I mean, we found that very early on. So one of the things that we do inside the platform is measure sentiment, because what you'll find is you'll have a member who will take the loneliness screening and score super high. And then when he or she is interacting with the chatbot, they'll literally say they're not lonely. And so you have to start to like develop a full picture around the end user. So they'll say things like, I'm sad, I'm tired, all the indications that we talked about in the physical response in the body. So critically important, you just don't treat the end user like a disease state or a diagnosis. You have to measure how they're feeling in the moment as they're engaging. And I call that measuring sentiment, because that will give you as much information around whether or not they're lonely as it is for them to say I'm lonely.
So Cindy, when folks were asked to come to this live recording, we offered everyone who registered the opportunity to pre-submit questions. And so I wanted to take a question from someone at the NCQA who asks, how should health plans be measuring quality related to addressing loneliness, and what metrics should they be held to? And I wonder, obviously, I think the measuring sentiment and some of the sort of proprietary and technical things that you guys have to look at, like around propensities, are probably too technical. But if you could maybe just outline, I know we touched upon some of this throughout the conversation today, but touch on some of those so the group could kind of write them down.
Yeah, I mean, listen, I think this is a simple answer. It's about like not recreating the wheel and looking at things you already have. Of course, there's always a debate in the industry over whether one intervention has actually made an impact over another, and we can talk about that at a different time. We're used to isolating this intervention, but here's how you measure. You look at utilization reduction. You look at med adherence improvement. You look at, of course, loneliness and depression reduction. And then finally, you look at overall health plan engagement. Like, we don't have enough time today to talk about this, but one of the byproducts of having a loneliness intervention is that we send 67% of people that use the platform go on to use a higher level of service that the health plan provides. So we like to think of ourselves as the tip of the spear, and that is a beautiful measurement. So get them engaged on your portal, get them using the community resources. Like for Michelle's markets, we go market by market and plug in the community resources that are powerful there. And then we track how many people we send there. So there are ways to measure stuff that's already built in. It's not all that complicated. And that's one of the things we pride ourselves on. You'll know right away whether this is working.
So some of the stuff's common sense: utilization reduction, medical adherence, loneliness, and depression reduction. I don't know if health plan engagement is necessarily a common sense. So that's one that's really interesting. How many of these folks now are re-engaging with their health? Right. I think I captured everything you said. Did I miss anything?
Yeah, you captured it. And you're right. I guess it isn't exactly intuitive, but it all just ties back to the science. Get people out of the stuck in mud, get them re-engaged in all the amazing resources that their providers and health plans provide. And that's success.
Michelle, I have a question from an audience member for you, but before we go there, do you have anything to add to how we address loneliness, quality measures?
No, I think you hit upon it perfectly. And again, the whole key is let's not reinvent the wheel. Let's leverage a lot of what we've got.
Got it. Actually, I'm gonna before I jump. No, I will. I'm gonna jump to you, Michelle. How do we incentivize MCOs to adapt strategies to overcome isolation?
Okay, that's a tough question.
Is
So
it similar to the PCP answer, or is it? It's
no,
actually
it's a fair question, and here's why it's tough for me. It's so intuitive. It's been part of Molina's DNA since the beginning. I mean, the correlation between loneliness and healthcare utilization is so strong that it's just, for us, it's a no-brainer. So the incentive is this is our job. So that's why it's a hard question.
got it. Understood. All right. I'm going to, I know we're coming close to the end here, and my co-moderators out there have been excellent. One of the best groups we've had in many years. So props out to everyone out there in Zoom land. Cindy, how do plans refer members to your platform, or do you screen all the members from the health plan first?
No, we don't screen all the members. We generally help them by looking at at-risk populations. And then we, of course, run the loneliness index on top of the at-risk populations. The other thing we do to find lonely members is that we get target lists from our partners. So that can be anything: new behavioral health diagnoses, ED admissions over the last 6 months, et cetera, et cetera. And then we actually do an active outreach to those folks. There's a real common misperception in healthcare. If you build it, everyone will use it. That's not how this works. You've got to meaningfully put a solution or an intervention in front of a member when they need it the most. And so we work with our partners to essentially develop target lists around populations, and then we reach out to those folks and get them engaged.
That's great. Great stuff. Really great stuff. I think we've hit everything I planned. A couple of things, just quick housekeeping announcements. Reminder to everyone about that feedback form, really important. And if you're an organization that's trying to reach payers and providers and want to expand their content marketing and their lead generation efforts and partner with Shared Purpose Connect through the Bright Spots and Healthcare platform, let us know. You could request a meeting with me or my leadership team to discuss that. So I encourage you to do that. I also encourage everyone, if you don't have this podcast on your phone or tablet, to subscribe. Spotify, Apple, Google Play, wherever. We're everywhere. Audible, Amazon, could go on and on. Find Bright Spots in Healthcare. Just write it in. You can type in my name. You'll find the show. Click subscribe. Obviously, it's completely free. And that way, any show that you miss or recording of the shows you want to listen to, again, will all just download right to your device. It's a really convenient way of consuming this content. It's obviously the audio only, and you can check out our YouTube page for the video version of that as well. Thank you, everyone who's listening. I tell you this every time. This is sort of your show. We work really hard to make sure this is 60 minutes of time well spent. We know you're really busy. We know it's a privilege to have your attention for this long. So thank you very much for tuning in, and continue to provide us that feedback. So hopefully we can deliver for you each and every episode. And Cindy, Michelle, great job today. I ask you to stick around for a minute before we end here, but great job, especially that it didn't seem like we were shorthanded. You guys really did a great job covering everything. So thank you for all that. This will mark the end of today's episode. Really appreciate it. Remember, this is Bright Spots in Healthcare, and this is your podcast. Take care, everyone.